Good morning all, I am Meghana from AIOS Nagpur. Today I want to discuss a disease which causes eye manifestations due to vitamin deficiency. Yes, you are right, it is Wernicke's encephalopathy, diagnosed by classical triad of end-gauge nystagmus or ophthalmoplegia with gait ataxia, with confusional states being the most common presentation. But this triad occurs only in 10% of population, occurring due to thiamine deficiency, either due to metabolic causes or due to chronic alcoholism leading to reduced absorption. Our patient is a 37 years old male who had complaints of binocular double vision since 4 to 5 days. No other systemic illness, but on personal history he is chronic alcoholic with consumption of 1.5 liters per day approach since 3 years. We can note horizontal gaze evoked nystagmus with limitation of left abduction in this patient. 9 gauge showing limitation of left abduction movements of this vision with IOP and color vision and diplopia charting. Anterior segment and fundus evaluation is normal in this patient. On neurological evaluation, the patient is having unsteady gait with ability to fall, suggesting ataxia. Further investigations revealed deranged hemoglobin levels with microcystic hypochromic anemia, and liver function tests are also deranged. Before starting treatment, we have done his thiamine levels which were reduced. His MRI is normal, so we have started him after admission in neurology ward with IV thiamine along with IM methylcobalamin with oral thiamine. 1 week follow up, the patient had improvement in left abduction. And mild improvement in ataxia is noted. Mild gait ataxia got improved. One more patient had similar complaints. He is a 30 years old male with double vision since 10 days, and he also had fever, headache, and vomiting, this patient with chronic alcoholism history. This patient also had end-gauge nystagmus, which we can note horizontal, but his vision, slit lamp evaluation along with fundus evaluation is normal. This patient also had unstable gait. His investigations are also similar, but MRI suggested hyperintensities in mammillary bodies. So he was also admitted under neurology and was started on similar treatments, but serum electrolyte correction also was done in this patient. My cases are unique because there is sudden onset binocular diplopia mimicking sixth nerve palsy, but he also had end-gauge nystagmus with diplopia charting is normal. So in these cases, it is mostly clinical diagnosis, careful history and neurological evaluation, which along with blood and neurological imaging has strengthened my diagnosis in this patient. Early recognition by ophthalmic manifestations led to timely diagnosis of the patient, and prompt thiamine treatment at appropriate time has avoided serious brain injuries in this patient. So while recovering, the order of recovery of the symptoms will be like confusion will recover early, ocular manifestations will recover later, ataxia will take much more time. So multidisciplinary approach involving ophthalmologist and neurologist has helped in well managing of this patient. These can be confused with sixth nerve palsy, which is a false localizing sign. So fundus evaluation and neuroimaging is also important in this patient. Thank you.
Nice. Dr. Meghana, you said binocular double vision.
Yes,
Can you elaborate more on the type of diplopia in both your cases?
My patient had when they are seeing with both eyes, they are having diplopia, ma'am. Like when they closed one eye, the diplopia disappeared, and the first patient had when he is seeing in left gaze, he is having more diplopia, ma'am. First patient.
So you have to mention horizontal. And crossed, uncrossed.
These patients has uncrossed diplopia only, ma'am, not crossed. And this Hirschberg test is also ortho in both patients, ma'am.
How long did you follow up the patients?
That first patient is 1 week, ma'am. The second patient is under follow-up now, ma'am. He presented recently only, 1 month ago. So his treatment is going on, ma'am. And that first patient is like 9 months ago, ma'am.
Can you tell what is the name of the irreversible type of Wernicke's when it goes into the irreversible phase?
Yes, ma'am. It is Korsakoff syndrome, ma'am.